Hello and welcome to a video on the heart. I wanted to cover some of the major structures of the different chambers and cover some of the major inflow and outflow tracts, as well as discuss some conduction as well as the lub and dub sound of systole diastole. So first off, the structures that you see here are going to be in the superior mediastinum. The heart is actually in the inferior mediastinum. This is separated by a T4, T5, or the sternal angle. The heart, as you can see, it has 4 chambers, but it doesn't sit like a square. You're actually seeing atria above what's called the coronary sulcus, the line that divides atria above from ventricles below. You can see that the right margin of the heart is formed by the right atrium, which contains this auricle, a feature of the atria. The right anterior margin of the heart is going to be the right ventricle. You see the interventricular sulcus here with some important vasculature inside. And then you have the left ventricle, which is the left border of the heart, and the posterior border of the heart is going to be the left atrium. So although it doesn't sit perfectly in the heart as one would expect, most of it is still in the center, with the apex pointing down into the left. As we cover some of the major features, it's important to discuss how blood flows in, flows out, as well as some of the conduction. So this is the 2 brachiocephalic veins, the left, which is longer, and the right, which conjoin to form the superior vena cava. The superior vena cava will then drain into what we see here as the right atrium. As we open this right atrium, we can actually see the superior vena cava coming from superior. The inferior vena cava will come from the inferior, which I'll show here, right here. So back here. And then we also have an opening for the coronary sinus. The coronary sinus is the big drainage point of venous blood from the actual heart itself. So it drains things like the middle cardiac vein, the great cardiac vein, and the small cardiac veins. So if the heart has its own drainage system, it's one of the 3 major things that drain here into the atrium. The right atrium has a smooth surface embryonically from sinus venosus, or the sinus venarium. And then we also have the primitive atria, which has the pectinate muscles. Remember, pectinate looks straight and they're in the atria. These are the contractile muscles of the right atrium. Most of the fill of the right atrium is passive. And as we'll see here, it used to have a shunt between the right and left atrium. What we're looking here is at the intraatrial septal wall. This remnant is called the fossa ovalis, a feature of the right atrium. It's also a feature of the left atrium. The limbus is just a little bit more visible here on the right atrium. As the baby starts to breathe on its own, this will close off. Now, if we look here, we can actually see the right atrioventricular valve cusps projecting into the right ventricle. We have a septal cusp, and we have 2 cusps here, anterior and posterior. These cusps are basically features that can create closure to allow for filling of the atria and projection through the outflow tract of the ventricle during systole. The specialized cardiomyocytes that actually are the SA node or the sinoatrial node are located near the fossa ovalis, near the superior vena cava. These specialized cardiomyocytes are basically considered the pacemaker of the heart. They send signals down to the AV node or atrioventricular node, which is right above the tricuspid. So really close to this tricuspid valve are the specialized cardiomyocytes of the AV node. Then we then have a bundle of His that divides into 2 pieces. One that goes down into the ventricular area on the right side of the ventricular wall, and then on the left side, on that septum, it goes over to the left wall. And these are called bundle branches, right bundle, left bundle. So it's SA node here, AV node, bundle of His, dividing into a right and left bundle branch. So let's take the tricuspid valve, this atrioventricular valve, into the right ventricle. Before we do, just remember that they may ask you the junction where things start to smooth off and the location of the specialized cardiomyocytes are nearby. This area is called crista terminalis, where we have the meeting point between sinus venarum and primitive atria. As we close the right atrium, notice there is an auricle. Remember, the A's go together. Auricle goes with atrium. Now, let's open up the right ventricular wall and actually look inside. As we focus a little bit more on the right atrium, we can see that there are 3 sets of papillary muscles. Instead of pectinate, we have this webby kind of meat in the ventricular walls called Trabecula carneae. That right bundle branch is coming over via Purkinje fibers and heading over to this specialized portion of the Trabecula carneae called the Septal Marginal Trabecula, which is this right here. And they also call it the moderator band. So this moderator band is connected to the anterior papillary muscle. Papillary muscles are features of the ventricle. And they're also specialized portions of the Trabecula carneae. So it kind of looks like a man or a woman holding on to a parachute with the strings. And so as these papillary muscles contract, they pull on these tendinous cords and yank the cusps into the ventricular system and allow closure of the valve. This will happen, this closure of the AV valve will form a lub sound. And then as we start to open this during that lub, this is what we call the right semilunar valve. And as we can see here, there are 3 cusps. They're not controlled by papillaries because they fill via diffusion. So we have on the on the pulmonic valve, we have an anterior cusps and a left and right cusp. So as this starts to close, it creates the dub sound. So lub, dub, for systole, diastole, respectively. Then we go out through the pulmonary trunk, which is more towards the left side. It's always very confusing to students to understand that you actually have a right ventricular valve, a semilunar valve, coming from that right ventricular system on this conus arteriosus, this outflow tract. But we actually end up on the left side of the body. So when we listen to this heart sound, it's in the second intercostal space on the left, even though it comes from the right ventricle. Believe me, they may ask you this as a quiz question or a lecture question or a board exam question. So coming from the right ventricle outflow tract, the sound is on the left second intercostal space. And then we head out via the deoxygenated blood that's actually on an artery. It's the one time in the adult that we actually see this. We have a left pulmonary artery and a right pulmonary artery, and they carry deoxygenated blood, which is why this model is blue. So then we have to head out from the right ventricle, out through the pulmonary trunk, out through the left and right pulmonary arteries to go to the lungs to exchange our oxygen, or to exchange our carbon dioxide for oxygen with the Bohr effect. And now we're going to take this oxygenated blood that's actually venous because it goes towards the heart. Arteries go away, veins go towards. So the right atrium, right ventricle are deoxygenated blood, but left atrium and left ventricle are oxygenated blood. So you have superior and inferior pulmonary veins that are draining into the right atrium, or sorry, the left atrium. If I can get it open here, there we go. And I'm going to lift this up. And now you can see that the left atrium is a little bit boring. We see the fossa ovalis here, right there. It's just not as visible as it was on the other side. It doesn't have the specialized cardiomyocytes on this side. But we see 2 cusps on a valve. We see an anterior and posterior cusp peeking in from the ventricular system. This is the left atrioventricular valve, also called the mitral valve, also called the bicuspid valve. And so as we pass into the left ventricle, we can see the 2 groups of papillary muscles, and they're receiving information from the left bundle branch, then to Purkinje fibers, and then to these specialized forms of the trabecular carneae called papillary muscles. We have papillary here, papillary in the back, 2 sets of papillaries on this one. So they use the chorda tendineae to, again, pull the atrioventricular valve closed during our lub sound, during our systole. And then our outflow tract is actually going to be behind. So I'm going to have to tilt this up again. And you can see that the left semilunar valve has a posterior cusp and a left and right cusp. So the way I remember it is that aortic valve doesn't have a P in it, so it needs more of the posterior cusp. And the pulmonary valve, pulmonic valve, doesn't have an A in it, so it needs the anterior cusp. So it'll have a left, right, posterior for this aortic valve. And then we're going to go through the ascending aorta. It's just as when you are on a plane, you're supposed to put the mask on yourself first, right? To take care of yourself so you can take care of others. The heart does the same. The only branches of the ascending aorta are the left and right coronaries. So let's take a look at those really quickly. So the left and right coronary arteries are in the coronary sulcus. The right coronary artery is here. And in the majority of the population, it'll give off the sinoatrial artery, also called the anterior atrial artery, that feeds the specialized cardiomyocytes going to the SA node. That gives you a right dominant heart. The right coronary artery gives rise to this right marginal artery. And as we turn it around, it typically, in most people, will give off the right posterior interventricular artery, also known as the right posterior descending by some surgeons. When you go to the left coronary is a little tougher to see because it's tucked underneath this auricle. Unfortunately, it's a model, so I can't move this part, but it'll be underneath the left auricle in the coronary sulcus. And it's called the widowmaker, unfortunate name, but it actually does apply, especially in the past before stenting. We have an anterior interventricular artery that's between the left and right ventricle, and then we have one that actually goes underneath called the circumflex artery. So circumflex artery in the coronary sulcus, and then left anterior descending or anterior interventricular artery. Then the circumflex artery will come around, giving off the left marginal, and then we'll collateralize with the right coronary to help give contributions to the posterior interventricular, also known as right posterior descending. The drainage of the venous blood goes into the coronary sinus that's in the coronary sulcus on this left and posterior side of the heart. It heads to the right atrium, but before it does, it has the great cardiac vein traveling with the anterior interventricular. The great cardiac vein then dumps into the coronary sinus that we see here traveling with the circumflex artery. You can see the tributaries all drain into this coronary sinus, as well as the middle cardiac vein on the back of the heart that travels with the posterior interventricular. This coronary sinus will then dump into the right atrium, as we discussed before, with the superior vena cava and the inferior vena cava. So that's your major drive of your structures here, as well as arterial supply and drain. Don't forget that the ascending aorta then becomes the arch of the aorta, giving rise to the brachiocephalic artery, left common carotid, and left subclavian. It will then make a turn backwards and towards the left, so that on slices that you guys observe, the left portion of the body can be signified by the descending aorta. This descending aorta will continue down and go through the diaphragm at the vertebral level of T12 and become the abdominal aorta. So it kind of looks like a weird candy cane when it's on the body. Remember that autonomics are driven by cardiac splanchnics, which are mostly from superior, middle, and inferior cervical sympathetic ganglia, mostly coming from T1, T3 lateral horn cells. And they synapse on either in the chain, but mostly on specialized ganglia in the cardiac plexus. And the autonomics that slow the heart are from vagus, also part of that cardiac plexus, driven by the dorsal motor nucleus. So hopefully you enjoyed this review of heart anatomy, as well as some of the circulation and conduction, and we'll see you next time.